Hello, you are most welcome, ladies and gentlemen, to Real Impartation Moment on Tuesday Night Anatomy with Daniel Okwan. Today's section, I want to quickly run through the brachial plexus using some kind of schematic, diagrams. And so, without much ado, let's set the ball rolling. So, before I go on with the brachial plexus, what I want you to know is that yes, we know that we have the brain and of course the spinal cord constituting the component of the central nervous system. And then emerging from these areas, you have what we call, the cranial nerves and of course the spinal nerves respectively. Now, I'm interested in the spinal nerve. So, the spinal nerves which emerge from, of course, the spinal cord will be formed. So each spinal nerve will be formed from, of course, ventral root, which, of course, that one will be motor in nature. And then, of course, dorsal root, which will be sensory in nature. And, of course, you know that the dorsal root will frequently present the ganglion, which is called the dorsal root ganglion. Now, what we are interested in is that when the ventral root and, of course, the dorsal root combine, then we are going to have, what we call the spinal nerve. Now, the spinal nerve, immediately it is formed, then it divides into two branches. And these branches are those things we call rami. So it will divide into what we call an anterior branch, that is the ventral ramus, and then of course a posterior branch, that is the dorsal ramus. But one thing that we have to know is that yes, the dorsal rami do not form a plexus, do not form any network of nerves. But the ventral rami, will be important in forming some kind of plexus. So for instance, cervical plexus, brachial plexus, talk about lumbar plexus, and of course, talk about, sacral plexus. So today we are interested in looking at what we call the brachial plexus, which is nothing but a plexus of nerves which will be important in giving motor supply to muscles of the, upper limb, as well as, of course, to the pectoral region. And not only that, but also to give, some kind of cutaneous sensation to the skin that is around these areas. So by the end of this, section, we should be able to understand the nerve supply to the upper limb as well as, the pectoral region. So if we talk about the brachial plexus now, you can see that these are bones of the vertebrae, actually cervical vertebrae. You can see them over here. Now, one thing is that emerging from these, areas, of course, we know that the spinal cord will dwell in it. Now, immediately we form the spinal nerve, then we are going to have what we call the ventral branches, as you can see here. Because we are taking an anterior view, then we can see the ventral, branches. So, in the posterior triangle of the neck, so if you want to visit the video that I've done on triangles of the neck, you understand these things. In the posterior triangles of the neck, then we are going to have the roots. So, brachial plexus will have what we call roots. So the roots of brachial plexus will come from the ventral rami of C5, C6, C7, C8, and T1. Of these spinal nerves that we are talking about. Now, one thing that we have to know is that brachial plexus could be prefixed or it could be postfixed. If you talk about the prefixed brachial plexus, that is when it's going to begin from C4. Instead of beginning from C5, it will begin from C4, then we call it C5, C6, C7, and of course C8. So without the inclusion of T1. Similarly, there could be postfixed brachial plexus, where this time around, instead of beginning from C5, rather begins as C6. So from C6, C7, C8, T1, and then we include T2 as well. So these are some kind of anatomical variations which, yes, are likely to be met. So, of course, looking at this normal anatomy from C5, C6, C7, C8, and T1, these are the roots of the brachial plexus. And I told you that they are going to be in the posterior triangles of the neck. Now, one thing that we have to know about these roots is that, yes, they will be found sandwiched between two muscles. And these two muscles are the scalenus anterior muscle, yes, anteriorly. And of course, behind, posteriorly, we are going to have what we call scalenus medius muscle. So this is scalenus anterior muscle, and of course, this is scalenus medius muscle. So these are the two muscles that the roots of the brachial plexus will be sandwiched, between. Now, the principle is that when I have C5 root, it combines with the C6 root so that I form what we call the superior trunk or the upper trunk. So if I have C5 root, it combines with C6 root to form what we call the upper trunk. Now, the upper trunk, the trunks are also in the posterior triangle of the neck. So remember that the roots, together with the trunks, will dwell in the posterior triangle of the neck. but C7 root stays the same without combining with any other and becoming what we call the middle trunk or the intermediate trunk. And of course, C8 root and C1 root will combine to give us what we call the inferior or the lower trunk. The lower trunk. So that is how these roots are going to combine. So C5, C6, upper trunk, C8, C1, lower trunk, then of course C7 staying alone to become what we call the middle trunk. Now, one thing that we have to know about the root is that from C5 root, now one nerve actually emerges from C5 root. Now that nerve is what we call dorsal scapular nerve. So we can see now this is C5 root. Now a nerve emerges from it, and that nerve is what we call dorsal scapular nerve. Now dorsal scapular nerve is going to supply muscles that attach to the dorsal aspect of the medial border of the scapula. Okay, so dorsal scapular nerve is going to supply 3 muscles, and all these 3 muscles will attach on what we call the dorsal aspect of the medial border of the scapula. They're actually going to insert there, and these 3 muscles are what we call levator scapulae, rhomboideus minor, and of course rhomboideus major muscles. Okay, so if you visit the videos that I've done on the thoraco-scapulohumeral muscles, please you can do that so that you get all these muscles that I'm talking about. Now, you know that there will also be some kind of nerve which will be coming from what you call the C5 root itself, and because that one will be supplying what you call combining with C3 and of course C4, so that we get what we call the phrenic nerve. Okay, so that one there will be some kind of contribution coming from this C5 over here. So from the C5 root we also have a contribution of phrenic nerve, because phrenic nerve is going to have root values C3, C4, C5. That small value from C5 is coming from the C5 root over here, as you can see. Now again, coming from the roots, which I will show you in another picture to demonstrate that one clearly. Yes, we'll be coming from C5 root, we'll be coming from of course C6 root, and then it will be coming from C7 root, and then we have a very long nerve which will be run. I will show you in the next slide. That one will be run along the lateral wall of the thoracic region, and that is what we call the long thoracic nerve. Long thoracic nerve. Now long thoracic nerve will supply only the boxes muscle, okay, serratus anterior muscle. All these muscles have demonstrated them. Please visit my video so that we can actually get all these things. And that is why if there is injury to of course the long thoracic nerve, it will lead to what we call winging of the scapula, because the serratus anterior muscle is also important in keeping the medial border of the scapula to the thoracic wall. Okay, so winging of the scapula, you see that of course the medial border of the scapula as well as the inferior angle will wing. Now I told you about this the dorsal scapular nerve supplying of course levator scapulae, rhomboideus minor, rhomboideus major. If you talk about these ones, if there is injury to of course dorsal scapular nerve, then it means that levator scapulae will waste or will become weak in its action, and therefore it can't really help in the elevation of the scapula. Again, rhomboideus minor and major will be very important in retraction of the scapula, saying that the medial borders of these scapulae will be getting closer to the middle of the body. And then antagonistic to that will be serratus anterior muscle, whose nerve supply is coming from C5, C6, C7, long thoracic nerve. And therefore you may not be able to punch, because for you to punch, then the need for what we call protraction of the scapula. So that is what you have to know. Okay, so coming from the root only, there are 2 nerves as far as this kind of upper limb as well as the thoracic region muscles will be concerned. That will be dorsal scapular nerve from C5 root, coming from C5, C6, C7 will be what we call long thoracic nerve. So please get to know that. But I told you that from C5 root again, which will be contributing to what we call the phrenic nerve to supply the diaphragm, will be coming off from this C5 root, as you see here. I'll show you in the next picture, other details. Now, one thing that I said that C5 root and C6 root will combine to form what we call the upper trunk, Now, this upper trunk, frequently, if there is injury to it, okay, because over here in the upper trunk, actually 2 nerves will be emerging here. It's not shown over here now. I'll show you in the next slide. That will be what we call nerve to subclavius, and of course, we also have what we call the suprascapular nerve. Nerve to subclavius, yes, it tells you what it's going to do. Yes, nerve to subclavius supply what we call the subclavius muscle. And where the subclavius muscle will be inserting? Yes, it will be inserting on the lower aspect okay, of what we call the clavicle, and therefore nerve to subclavius will be very important as far as depression of the clavicle is concerned. Again, if the clavicle being the insertion point is fixed, then of course it's able to move the origin. It's attaching to, of course, the first rib, and therefore help more or less move the first rib superiorly. Okay, so that's what I want you to know. Then there's what we call the suprascapular nerve, also coming from the upper trunk. Therefore, it tells us that the root values of nerve to subclavius and suprascapular nerve will be, of course, C5, C6, because they are coming from the upper trunk. Upper trunk is from C5 and of course C6. Okay, so nerve to subclavius, you've seen what it's going to do, supplying the subclavius muscle, and then of course suprascapular nerve will be supplying supraspinatus muscle. Supraspinatus muscle is important in initiation of abduction, 0 to 15 degrees abduction by nerve supraspinatus muscle, where nerve supply is coming from what we call suprascapular nerve. Not only is it supplying it, but it also supplies what we call this infraspinatus muscle. And infraspinatus muscle will be very important as far as lateral rotation at the shoulder joint is concerned. After all, it is one of the steering muscles or the rotator cuff muscles. Okay, so that is what we have to know over here. Okay, that is the upper trunk. Now, the upper trunk, one thing that you have to know about it is that 6 nerves are meeting over here, 6 nerves. And these nerves are C5 roots, C6 roots, then we said nerve to subclavius, and then of course suprascapular nerve will also be meeting there. Then apart from that, immediately, now one thing is that if I have the trunks will divide into anterior and posterior divisions. So you can see that this upper trunk is divided into an anterior division and of course a posterior division. Okay, so once I have this, then I know that 6 nerves will be meeting over here. And that is why at the middle point of the upper trunk, we have something we call Erb's point. And therefore, injury to the upper trunk will lead to what we call Erb's palsy. Now, I explained the clinical update in our next video so that you try and understand, this kind of clinical thing that we are talking about. Now, remember that Erb's palsy, the presentation of the patient is what we call policeman tip deformity, or the waiter's tip deformity, or porter's tip deformity, where essentially, yes, what happens is that the upper limb turns into what we call medial rotation essentially, and the movement which will be lost, that's Fice movement, flexion, extension, abduction, as well as of course external rotation, of course supination. All these movements will be lost. I will explain the clinical aspect in our next video. So that's the upper trunk. Now in the middle trunk, no nerve emerges from middle trunk. In the inferior trunk, no nerve emerges from the inferior trunk. So these are the things that you have to know, okay, regarding these ones. And as you can see from this schematic diagram, you can see that the superior trunk is a bit longer compared to as you descend from middle to inferior. Because they are small, no nerve actually emerges from here. But superior trunk or the upper trunk, yes, it's having 2 nerves emerging from this area. Okay, so that is what you can be asked. You can be asked which of these trunks would nerves come from. That is what we call the superior trunk, only the superior trunk. Although the inferior trunk, no nerve is coming from there. Now, if there is going to be Erb's palsy, and that's injury to upper trunk, then it's usually due to what we call downward traction at the neck region. And so during delivery, yes, of what we call a woman who is in labor, then care must be taken not to injure, the fetus or the newborns, upper trunk. We will look at that clinical aspect. But downward traction at the neck region will lead to what we call injury to the upward traction in the neck region will lead to injury of the lower trunk. And that is what we call Klumpke's palsy. So we look at the clinical application, later on. And at the end of the day, yes, essentially what will happen is that it will lead to some form of claw hand and what have you. I will explain, that one, later. Where of course, if the cervical parasympathetic nerves are involved, it will lead to what we call Horner syndrome, which of course clinically, yes, we talk about enophthalmos, we talk about meiosis, loss of spinociliary reflex, talk about anhydrosis, and of course so these are some kind of clinical manifestations that we tend to see with this kind of and of course ptosis is also one of the clinical presentation of what we call Horner syndrome. We'll look at that clinical aspect later. Now immediately I have my trunks, then the trunk, each of the trunk we divide into an anterior division and a posterior. So there's anterior division of upper trunk, posterior division of upper trunk. There's anterior division of middle trunk, posterior division of middle trunk. This is what we call anterior division of upper trunk, and of course, anterior division of lower trunk, and this is what we call posterior division of lower trunk. So you get all these divisions. I said divisions will be below the clavicle, will be infraclavicular in nature, together of course. Now, whenever I have these divisions, there is no nerve directly coming from the divisions, but these divisions will organize themselves in a particular fashion to give us what we call cords. And these cords are what we call lateral cord, yes, medial cord, and of course posterior cord. Now, in forming the lateral cord, it is formed from what we call the anterior division of what we call upper trunk and anterior division of middle trunk, forming what we call the lateral cord. Now, for the medial cord, it is formed from only the anterior division of the lower trunk. So lower trunk stays the same to become what we call the medial, cord. Then, of course, for posterior cord, it is formed from all the posterior divisions of these trunks. So posterior division of upper trunk, posterior division of middle trunk, and of course posterior division of lower trunk will combine to form what we call the posterior cord. Now remember, this nomenclature of calling the cords, yes, naming them either lateral, posterior, or medial, is based on their relation with what we call the second part of the axillary artery. So that if you are related laterally to this second part of this axillary artery, then you are called lateral cord. If you are related medial to it, then you are medial cord. But if you are related behind or posterior to it, then you become what we call posterior cord. Now, these cords from here will give off the terminal branches of what we call the brachial, plexus. Terminal branches of the brachial plexus, which of course I said will be in the axilla, in the armpit. Over here we are in the armpit area. Okay, so these are the things that I want you to actually know. Now, although, yes, I'm going to show you these ones, but I'm not going to show you all of them. Let me use the next one. So, now one thing about the brachial plexus, which will frequently be important to you, helping you, especially if we are looking at the real-time sections, and then the structures are puzzling, look for this M-shaped structure that you find over here. This M-shaped structure. Okay, and that one will help you go a long way to help you know, the branches we are talking about. Say that, the middle point of this M is what we call a median nerve, because median nerve will have two origins, and therefore the one which is, lateral, this one becomes the lateral root of median nerve, and this portion becomes the medial root of median nerve. Once you can know that, you can trace to get the respective, course. Say that, in that side which relates to, of course, the medial roots of median nerve, as you go distally, you get a medial cord, and that portion which is related to, of course, the lateral root of median nerve, as you go posteriorly, you get, as you go distally, you get, or as you go proximally, actually, you get what you call the lateral cord. And then, of course, having got that, then that one branch of that M which is related to the lateral cord will be the muscocutaneous nerve. I'm going to show you. And then, of course, I say this is the median nerve. Then the other portion of the M branch will be, of course, the ulnar nerve, the longest nerve as far as the brachial plexus is concerned. So that is what I want you to know over here. Okay, now let me show you something. Now you can see there's another nerve over here. That's the axillary nerve, which winds, around, of course, the cervical neck of the humerus. Okay, actually going through what we call the quadrangular space. And of course, muscocutaneous nerve will pierce what we call the coracobrachialis muscle. When you're looking at the muscles, you look at all these things. And then, of course, radial nerve will, of course, go behind the, the humerus by going through what we call the spiral groove or the radial groove, alongside the profound brachial artery. So please, these things. And then, of course, median nerve, I said it's going to be in the middle, supplying, yes, muscles that we're going to find in most of the muscles in the anterior compartment of what we call the forearm, and of course, in the hand region, as well as giving some cutaneous innervation. I've done all these long nerves. I've done the radial nerve, median nerve, ulnar nerve. So visit those videos to get more insight in this regard. Then, of course, ulnar nerve will supply, medial aspects of what we call the hand region. The forearm, and of course the hand region. I've done all these things. Please visit those videos. And then, of course, musculocutaneous nerve, after piercing the coracobrachialis muscle, yes, it's going to supply muscles in the anterior compartment of the arm, and that's the BBC muscles, yes, bicep brachii, brachialis, and of course coracobrachialis muscles. So these are those things that we are looking at. So yes, giving us that kind of summary, what we are saying is that we are having the brachial plexus coming from C5 all the way to T1 ventral rami. These C5 and C6 root combine to form what we call the upper trunk, and then C7 staying alone to form the middle trunk, and then C8 and T1 becoming of course the lower trunk. Then in that regular fashion, yes, the anterior division of upper trunk, and then anterior division of what we call the lower trunk, because we said that these trunk will eventually divide into anterior and posterior divisions, anterior and posterior divisions, anterior and of course posterior divisions. So once we can get these ones, then they are going to organize themselves in a particular fashion. So we said that anterior division of upper trunk and middle trunk will come together form lateral chord. Then of course, anterior division of what we call middle trunk, yes, will stay to become what we call the medial chord, and then all the posterior divisions of these trunks will become what we call the posterior chord, and then from there we get the terminal branches. Now to get the terminal branches, then it's very important that we use some kind of mnemonic, some kind of learning aid to help us remember all these things. And this mnemonic is for lateral chord. Okay, so over here we are having the lateral chord. Now lateral chord, the mnemonic is LML. So begin with L. So tell you that it's lateral chord LML, and L over here, one of the L's is what we call lateral pectoral nerve. So lateral pectoral nerve, we know, is going to supply what we call pectoralis major muscle, but sometimes even will supply pectoralis minor muscle, and therefore at times pectoralis minor becomes a hybrid muscle because we'll be having dual innervation. Then apart from that, yes, I told you that look for this M-shaped structure, this muscle over here, this M-shaped structure that you find over here, and that one is what we call the median nerve. Now the lateral aspect of this median nerve, we are going to have what we call lateral roots of the median nerve, lateral roots of the median. So the other L, I said LML. So the first L is lateral pectoral nerve, the last L is what we call the lateral roots of the median nerve, and then the M is what we call the musculocutaneous nerve. Musculocutaneous nerve. The name is musculocutaneous nerve because it's going to supply muscles of the anterior compartment of the arm. Then after that, it becomes what we call lateral cutaneous nerve of the forearm. So that's why we are calling it musculocutaneous nerve. So it's a mixed nerve actually, giving both motor and of course cutaneous nervation. So these are the nerves. Now one thing is that for you to know the root values of these nerves, yes, that is what we call, that is, LML, L lateral pectoral nerve, musculocutaneous nerve, and of course, what we call the lateral roots of what we call the median nerve. Yes, then it's going to start because there are three, and the brachial plexus is coming from C5 all the way to T1. The first three root values will be coming from them. So from from C5, C6, C7, all these three nerves coming from the lateral chord will have root values C5, C6, C7. Okay, then when you go to the medial chord, okay, so this is the medial chord over here. This is the medial chord. A medial chord is going to have 5 branches. So 5 branches will come from the medial chord, and simply with a mnemonic, M for U. So there are 4 M's and 1 U. U is obviously the ulnar nerve, and then the M, the first M, we saw that there was lateral pectoral nerve. Okay, so it means that coming from the medial chord, yes, we are going to have, okay, now this one is not really shown very well, but we are going to have what we call medial pectoral nerve. Medial pectoral nerve will be coming from what we call the medial chord of the brachial plexus. Medial chord of that's the medial pectoral nerve. Okay, that will be coming from, of course, the what we call the medial chord. Then apart from that, we said that yes, if you look at this M-shaped structure over here, you know that in between this, middle portion is the median nerve, and therefore over here, this one becomes what we call the medial roots of the medial nerve. Okay, medial roots of the median nerve. That becomes the, the other M. So there are other 2 more M's. No, the other M's will be what we call, the lateral, we are going to have what you call, this is there. So over here, this we are going to call what we call the medial cutaneous nerve of the arm, and of course you are going to also have medial cutaneous nerve of the forearm. So those ones complete the 4 M's we are talking about, and then from there we are going to have, of course, the ulnar nerve. So we can see the ulnar nerve coming from, of course, the medial root of what we call medial aspect, coming from the medial chord. Actually, ulnar nerve, I said ulnar nerve is the longest nerve of the brachial plexus. And for ulnar nerve, one other thing that you have to know in real-time sections, what you see is that ulnar nerve will be piercing what you call the medial intermuscular septum, so that it runs behind, going behind what you call the medial epicondyle. Okay, that's why it's palpable at the medial epicondyle, and therefore when it gets trickled, then you find that funny feeling, making it, the humerus to be called the, funny bone. So that is the ulnar nerve. Where the coracobrachialis muscle inserts, this nerve will pierce what you call the medial intermuscular septum. That's how you identify it. Okay, now for you to know the root values, now one thing that you have to know is that, I talked about, medial pectoral nerve. Now, medial pectoral nerve is actually supposed to come from what you call the medial cord. Okay, so medial pectoral nerve, as well as, of course, medial cutaneous nerve of arm, and of course medial cutaneous nerve of forearm, they are root values. Yes, they are the lower level, so that will be from C8 and T1. Now for ulnar nerve will have root values, C7, C8 and T1, because it gets a communication branch from C7. Okay, it gets some kind of communication branch from C7. So actually, yes, because it's coming all the way this way, yes, if you really trace it, it's coming from what you call, C8 and T1, but it receives a communication branch from C7. Okay, that is the, ulnar nerve. Then for the posterior cord, yes, that one too, you can see 4 or 5 branches, depending on how you want to explain it. And I have a mnemonic for it, that is star, S-T-A-R. And star for S for what you call subscapular nerve. So subscapular nerve, we have upper and lower subscapular nerve. Okay, so upper and lower subscapular nerve. That one, yes. So over here, so this is actually showing you the lower subscapular nerve. And then of course you also have what you call upper. So I'm going to use this one for the upper. So we have upper subscapular nerve, and then of course you also have what you call lower subscapular nerve. So one thing that we have to know about upper subscapular nerve is that, yes, upper subscapular nerve will be supplying, what you call only, subscapularis muscle. And subscapularis muscle, yes, is very important as far as, talking about medial rotation at the shoulder joint is concerned. So upper subscapularis muscle, upper subscapular nerve will be supplying only subscapularis muscle. But lower subscapularis muscle, lower subscapular nerve will supply, yes, apart from, subscapularis muscle, will also supply what you call teres major muscle. Please get to know that. And so that is when, so you have to anticipate which muscles are supplied by these ones, so that, yes, if there is injury, to them, then we know what, yes, we are looking at. Then, so that is the, upper and lower subscapular nerves. Remember, upper and lower subscapular nerve, yes, they will be supplied by what we call C5, C6. So we start again, C5, C6. Okay, so that is what we have to know. Then, so that's the S for the in the star, then T for thoracodorsal nerve. So coming from the posterior cord, yes, we are having what we call thoracodorsal nerve, and that is what also called nerve to latissimus dorsi. So it's going to give motor supply to latissimus, latissimus dorsi muscle. Then A for axillary nerve. Now I told you that axillary nerve, yes, that one will be running, okay, coming from posterior cord. That one will be running in what we call the quadrangular space, yes, winding around what we call the surgical neck of the humerus, and it's going to supply what we call the deltoid muscle, as well as, teres minor muscle. Remember, teres major muscle is supplied by lower subscapular nerve. Okay, so that is what we have. And then of course that one is also having root value C5, C6 root values. And then if you look at now, nerve to latissimus dorsi or thoracodorsal nerve will be having root values actually C5, to what we call C8. Sorry, C6 to C8. C6 to C8. C6 to C8. So C6, C7, C8 root values, thoracodorsal nerve. Then of course radial nerve, okay, we know radial nerve is going to supply muscles in the posterior compartment of what we call the arm, as well as the forearm and the hand area. So that one, radial nerve, is having root values from all the roots. That's C5 to T1. So that's radial nerve, giving motor supply as well as cutaneous innervation. So this is just the anatomy, and we look at the clinical aspects of this brachial plexus that we just looked at. Thank you very much, and may God richly bless you.